the round window and the round window membrane. The round window serves to decompress acoustic energy that enters the cochlea via stapes movement against the oval window. Any inward motion of the oval window via stapes vibration leads to outward motion of the round window. Occlusion of the round window is a cause of conductive hearing loss because it increases the resistance to sound energy and consequently dampens energy propagation. Because the round window niche is not adequately evaluated by otoscopy and may be incompletely exposed during surgery, otologic surgeons may not always correctly identify associated pathology. Thus, radiologists play an essential role in the identification and classification of diseases affecting the round window. The purpose of this review is to highlight the developmental, acquired, neoplastic and iatrogenic range of pathologies that can be encountered in round window dysfunction. The round window serves as a boundary between the basal turn of cochlea anteriorly and the round window niche posteriorly. It, along with the oval window, is of one of two natural openings between the inner and middle ear. The round window is often overshadowed by the first window, which is the oval window, and pathologic third windows, example, superior semicircular canal dehiscence. Nevertheless, numerous developmental, acquired, neoplastic and iatrogenic processes can affect the round window membrane and niche. Any of these can cause conductive hearing loss because occlusion of the round window prevents propagation of acoustic energy along the cochlear axis. Inoperative interventions in which a primary goal of surgery is to improve conductive hearing loss or access the round window region for cochlear implantation, accurate preoperative identification of round window abnormalities is essential to first determine whether surgery is a worthwhile endeavor and subsequently to guide the surgical strategy. In this presentation, the various pathologic entities and surgical considerations of the round window that can be encountered on imaging are reviewed. This is a beautiful picture of the round window membrane, that is a round window and the round window membrane. Again, this is the round window niche and deeper within is the round window. The round window membrane is located at the end of the scalar tympani, where the hook bends posteromedially. From the exterior, it is located under a bony overhang called the tegmen, formed by the promontory wall of the cochlea. It is hardly seen by the surgeon due to the niche and a mucosal fold. Initially, the technique used to insert a cochlear implant was through the round window. This was later abandoned for the drilling of a cochleostomy to enter the scalar tympani. Because of the modulus being in the way and the crista fenestra, when using the round window approach, it was considered better to make a cochleostomy a few millimeters in front of the round window membrane for positioning of the electrode along the outer wall. Round window membrane was described by Scarpa in 1772. He gave credit to Gabriel Fallopius for discovering the round window membrane and Fabricius de Acopendent for the first pictorial delineation. In a more recent translation edited by Sellers and Anson, Scarpa's thorough description can be accessed and appreciated. They already then disagreed on the true shape of the round window membrane. Scarpa states that this membrane is not flat as anatomists had thought, but instead conical. Scarpa proposed the term secondary tympanic membrane and believed that it played an even larger role for the transmission of sound into the inner ear. Politzer referred to the round window membrane as round window of Scarpa. Dimensions of the round window membrane. The membrane itself has an average of 2.3 mm according to Proctor. It does not grow postnatal. Sue found the minimum diameter to be 1.08 and the maximum diameter to be 2.28 millimeters based on data collected on as much as 463 specimens. Many authors do not seem to have considered the ovoid shape of the round window membrane. Now, this can be due to the histologic studies where it is difficult to realize its three-dimensional structure. The round window in human is not ovoid but is not round but ovoid with a long and short diameter. Adult dimensions are reached early during fetal life. Although individual values vary considerably, placement of a standard cochlear implant array with a maximum diameter of 1.0 mm through the round window membrane should be possible. In most cases, several electrodes today have dimensions below the size of 1 mm. The round window membrane is formed like a saddle or a Pringle chip. It consists of an infero-anterior vertical and a posterior-superior horizontal part. In the posterior part, the membrane lies very close to the laminae spiralis ossea with a distance of around 0.1 mm. In the center, this distance is around 1 mm. The thickness of the membrane varies between 50 and 100 micrometer and separates the fluid of the internal ear from the gas-filled space of the middle ear. The thinnest part of the round window membrane is the center, which can rupture if the sinus tympani perilymph hydrostatic pressure rises relative to the middle ear pressure. The middle ear mucosa that covers the outer surface of the round window membrane contains blood vessels and nerve fibers. The round window membrane is suspended in the otic bone through a fibrous ring. The epithelium facing the middle ear is of low columnar or squamous type and consists of cells held together with tight junctions and a basal lamina. There is a thin laminae propriae that contains connective tissue, nerve fibers, and blood vessels. A secondary membrane called a pseudomembrane or fold usually tapers the round window niche, but not always. It can be incomplete and adherent to the round window membrane. One must therefore be careful not to remove this membrane directly during surgery because it can tear the round window membrane. A small nerve innervating the round window membrane from the spiral ganglion region penetrates the fibrous layer. Theoretically, and because there are morphologic similarities with other mechanoreceptors in the body, it could sense and monitor perilymph pressure. Interestingly, these anatomical structures were not found in quadrupods, suggesting that upright posture in humans may require additional regulatory mechanisms for fluid homeostasis. The entrance to the round window membrane forms a small space called the fossulae fenestrae rotunda. Its maximal diameter is 2.98 mm and its shape varies greatly. Its appearance may puzzle the surgeon and make him believe that the round window membrane has been erroneously misplaced with a partly ossified entrance, mistaken for the membrane itself. This is a beautiful picture of the cochlea, and this is the scalar tympani, the end of which is closed by the round window membrane. Again, this is a picture of the round window. It's a micro dissection showing the round window in a right human temporal bone. The subiculum, which is here, and the posterior, which is here, are shown, while the posterior anterior was removed to outline the round window membrane. The crista fenestra, fan shaped, is seen inferiorly. Again, this is the cochlear cross section showing the round window, and here it is the dissected left side human cochlea. The round window opening can be seen from inside the scalar tympani near the internal opening of the cochlear aqueduct. Higher magnified inset here illustrates the small crest that separates the aqueduct from the basal aspect of the round window, which appears fan shaped, and that is the fan shaped. Micro dissected human left side inner ear. This is the round window opening. These are beautiful pictures of the cochlea. Physiology and functionality. The inner ear windows refer to openings in the otic capsule that connect the fluid in the inner ear to either the middle or intracranial space. The two primary natural openings are the oval and round windows. Other windows include the cochlea and vestibular aqueduct and tiny foramen that transmits vessels and nerves to the inner ear and adjacent structures. Functionally, the role of the oval and round window is related to sound transmission. Vibratory acoustic energy enters through the oval window, transmits through the cochlea, exits into the middle ear cavity via the round window. The fluid in the cochlea through which sound is transmitted is functionally incompressible due to the surrounding osseous structures. Movement of the cochlear fluid is therefore dependent on the mobility of the round window and oval window membranes. Inward displacement of the oval window membrane via the stapes by ossicular vibration is matched by outward round window membrane displacement. Anatomy. The round window is located along the posterior aspect of the cochlear promontory and measures 1.5 to 2 mm horizontally, 1.9 vertically, and 0.6 mm in thickness. The round window membrane is thicker along its edges and thinner in the middle and is made up of three layers. Two epithelial layers facing the inner and middle ear respectively, and connective tissue in the core. Contrary to its name, the shape of the round window is typically skewed, ovoid, and non-planar according to a recent study. The round window niche is primarily defined by the relatively thin overhanging bone that naturally extends from the promontory. This overhanging bone may obscure complete direct visualization of the round window membrane during routine middle ear surgery and cochlear implantation. In addition, most ears have a thin layer of mucosa covering the round window membrane, often called a pseudomembrane, that blocks direct visualization of the window if not removed. Round window stenosis and atresia. Round window absence is a rare abnormality that may be seen in conjunction with various syndromes, including incomplete partition anomalies, mandibulofacial dysostosis, coloboma of the eye, heart defects, atresia of the choanae, retardation of growth and or development, genital and or urinary abnormalities, and ear abnormalities and deafness syndrome, namely the Chard syndrome. In addition to cases of oral atresia, in very rare cases, it may also occur without an associated syndrome. Some authors have posited that such non-syndromic cases may represent an inherited autosomal dominant genetic disorder with variable penetrance. Even in non-syndromic cases, few reports exist of round window atresia as an isolated finding. Most of these patients have associated middle ear or pinna abnormalities. Patients with round window atresia typically have a mixed but predominantly conductive hearing loss, with an associated typical airborne gap of 40 decibels. Attempts to surgically recreate the round window do not always produce substantial gains in hearing. The reasons remain uncertain because few such surgical case reports exist. However, the inconsistent results may be related to the presence of associated anomalies such as congenital staple fixation, otosclerosis, reossification following surgery. Unfortunately, because surgeons often have incomplete exposure of round window niche during routine otologic procedures, and because of its rarity, round window atresia can easily be overlooked intraoperatively. It also is frequently missed on imaging, and many patients with round window atresia are not diagnosed until middle ear explosion. Close attention must be therefore be paid to the morphology of the round window and round window niche in or on imaging performed for conductive or mixed hearing loss. Stenosis of the round window membrane and or recess is more common than complete round window absence. Like round window atresia, stenosis of the round window can have syndromic associations and contribute to hearing loss. The lower limit of normal size for the round window niche is generally cited as being 1.5 mm. Nevertheless, Imaging characteristics of stenotic recesses can be quite variable and range from mild to severe. Acquired abnormalities. Acquired abnormalities that affect the round window include a range of traumatic, inflammatory, and iatrogenic processes. Otitis media associated with mucosal thickening and effusion may obscure the round window or adjacent niche. Less commonly, barotrauma or increased pressure may cause the round window membrane to rupture, leading to perilimb fistula with sensorineural hearing loss and vertigo. Temporal bone fractures through the round window may disrupt membrane. Several primary osseous processes such as Paget's disease, fibrous dysplasia, autocephalus, and osteogenesis imperfecta can affect the temporal bone, including the annular ring of the round window. Let us now discuss several of the most common causes of acquired abnormalities of the round window. Labyrinthitis ossificans. Labyrinthitis ossificans refers to ossification within the membranous labyrinth, most frequently occurring within the scala tympani. Typically, labyrinthitis ossificans is secondary to inflammatory changes from infection such as suppurative otitis media, labyrinthitis, or meningitis. Though trauma and otosclerosis have also been indicated as inciting processes. In cases of labyrinthitis ossificans associated with bacterial meningitis, the basal turn of the cochlea is often preferentially affected because infection may spread from the subarachnoid space through the cochlear aqueduct to the proximal scalar tympani. In some cases, labyrinthitis ossificans may involve the round window, involvement thought to occur when the inciting event is otitis media or meningitis that spreads through the round window along the scalar tympani. The etiology of labyrinthitis ossificans cannot be predicted on the basis of mineralization patterns seen on CT. Labyrinthitis ossificans is associated with the development of sensorineural hearing loss and may render cochlear implantation more challenging and outcomes less rewarding. Extensive labyrinthitis ossificans may preclude the placement of a cochlear implant. Expected CT findings of labyrinthitis ossificans involve the round window including thickening, high attenuation along the membrane, likely with coexistent ossific material in the basal turn of the cochlea or elsewhere in the membranous labyrinth. In the early stages of labyrinthitis, fibrosis may be evident only on heavily weighted T2 imaging, where low signal is seen within or partially replacing normally high signal perilymph. Otosclerosis. Otosclerosis is an acquired condition in which spongiotic bone replaces mature endochondral bone of the otic capsule. Typically, otosclerosis involves the oval window and stapes footplate in the region of the fissula antifenestrum. Fenestral otosclerosis may also secondarily involve the round window in approximately 13% of cases. Isolated round window otosclerosis has been reported, though the prevalence is rare. Nevertheless, secondary involvement or isolated involvement of the round window by otosclerosis is an important radiologic observation because it portends a poorer chance of surgical success. Specifically, round window involvement diminishes the movement of perilymphatic fluid following stapedectomy and prosthesis placement, the surgery typically used in otosclerosis. The appearance of otosclerosis on imaging depends on the disease phase. In the active otospongiotic stage, the affected bone surrounding the round window will appear lucent and demineralized. Later on, these areas are replaced by sclerotic bone due to the non-active stage. As this replacement occurs, the round window membrane may become thickened or irregular. Heaped up osseous plaques may narrow the round window or adjacent niche. Jugular bulb dehiscence and diverticulum. The positional anatomy of the jugular bulb is variable throughout a person's life. Jugular bulb abnormalities consequently develop with time and are typically acquired by the 4th decade of life. High riding jugular bulbs are found in approximately 8% of patients, both on pathologic specimens and CT images. Dehiscent jugular bulbs and jugular bulb diverticula are more rare, occurring at a rate of 2.6 and 1.2% respectively. High-riding jugular bulbs, dehiscent bulbs, and jugular diverticula are often asymptomatic. However, they may also present with pulsatile tinnitus or less commonly conductive hearing loss, likely related to encroachment by the bulb on the round window, ossicular chain, or tympanic membrane. The incidence in which the round window membrane is specifically involved is rare. Histologic analysis of temporal bones identified just 2 cases in 1,579 specimens. Neoplastic processes. Several neoplastic processes may affect the round window membrane or the round window niche. Some, such as metastasis and primary osseous tumors, are centered in the bone. Secondary round window involvement by these lesions depend on their size and location. Notably, most primary osteodystrophies and osseous neoplasms spare the otic capsule given divergent embryology and composition. Other tumors have an anatomic proclivity to involve the round window membrane. For example, intralabyrinthine schwannomas may extend through the round window membrane into the niche. CT images of such patients may demonstrate soft tissue mass within the niche, and visualization of the entire lesion often requires MR imaging. Jugulotympanic paragangliomas, comprising of glomus jugulare and glomus tympanicum tumors, may also involve the round window. Glomus tympanicum tumors arise from the tympanic nerve, that is the Jacobson's nerve, and grow within and along the cochlear promontory. If large enough, they may extend into and occlude the round window niche. Glomus jugular tumors begin within the jugular foramen. Although histologically benign, glomus jugular tumors are locally destructive and can erode into adjacent middle structures such as the round window niche. Surgical considerations, surgical access and round window visualization. Several conditions may require surgical dissection at the round window niche. Most commonly, the niche is accessed during cochlear implantation. Most cases are performed using a standard cortical mastodectomy with facial recess. The bony overhang of the round window niche is then drilled to allow direct round window membrane visualization during electrode insertion. Conversely, when surgical access of the round window or niche is performed to treat infections or neoplastic miliary processes, the region is typically visualized via a transcanal approach. Conclusions. Numerous acquired and developmental processes may affect the round window, presenting with varying clinical symptoms. Such cases can be challenging to radiologists who are unfamiliar with the local anatomy and pathologies. Nevertheless, because the round window and round window niche are often anatomically obscured during an operation, imaging plays a uniquely important role. Thus, radiologists should scrutinize the round window and familiarize themselves with the anomalies and disease processes that may be encountered in this important anatomic region. Let us have a look at some of the recent advances and notes relevant to this area. Endoscopes recently have gained popularity in otologic surgery. Endoscopy allows superior visualization around corners, particularly during removal of a cholesteatoma in the sinus tympani and anterior epitympanum. Thus, endoscopes are sometimes used to augment microscopic techniques in complex cases. However, for visualization and access of the round window, the use of an endoscope does not carry a substantial advantage over microscopic visualization in most cases because the round window niche is readily seen when performing either transcanal or transmastoid facial recess surgery via a direct line of sight. Postoperative changes in third window lesions. Third window lesions refer to any range of pathology that creates an abnormal connection between the inner ear and either the middle ear or intracranial cavity. Acoustic energy is lost through these windows, often causing a so-called pseudo-conductive hearing loss, which manifests as increased bone and decreased air conduction. There are many such connections: vestibular aqueduct enlargement, semicircular canal dehiscence, and any other type of osseous thinning between the inner ear and adjacent vascular nervous channels. Patients can present with Tullio phenomenon, that is, vertigo symptoms induced by loud noises, or the Henneberg sign, similar symptoms induced by increases in pressure within the ear canal due to deflection of the superior canal cupola by endolymphatic fluid escaping the osseous defect. For cases of superior semicircular canal dehiscence, surgical plugging of the pathologic osseous defect can be completed either via the middle cranial fossa craniotomy or transmastoid approach. Alternatingly, the round window can be targeted. Surgeons may reinforce the round window with overlying tissue, for example fascia or cartilage, or occlude the round window niche. Currently, most authors favor the former approach over the latter. Although round window occlusion is considered low risk, this strategy may induce conductive hearing loss. Furthermore, the theoretic physiologic justification for this approach is lacking because occlusion of the round window should theoretically create preferential shunting towards the pathologic third window. Cochlear implants. Cochlear implants may be inserted through a cochleostomy adjacent to the round window or directly through the round window membrane. Most surgeons surveyed preferred the former approach, though these decisions may be based on historical presumptions. Earlier, multi-channel leads were thought to traumatize the cochlea if placed through the round window. A more recent survey found that today most surgeons prefer round window membrane electrode insertion given the natural and less traumatic access provided to the scala tympani, the preferred location of electrode placement. A recent study found no differences in the number of audiometric outcomes or post-operative complications among groups undergoing electrode placement via either approach. However, most cochlear implant surgeons now prefer the round window approach when trying to preserve any residual natural acoustic hearing. Regardless of the cochlear entry point, complications do occur. The electrode can kink, flip over its tip, or migrate. Post-operative imaging can also demonstrate various degrees of electrode displacement, including within the semicircular canal, internal carotid artery, internal auditory artery, and vestibule. Across time, electrodes may migrate from the initial position. Post-operative images should be evaluated in the context of surgical approach, that is, via the round window or adjacent cochleostomy, and should include an assessment of electrode position, integrity, and change since prior examinations. Conclusions. Numerous acquired and developmental processes may affect the round window, presenting with varying clinical symptoms. Such cases can be challenging to the radiologists who are unfamiliar with the local anatomy and pathologies. Nevertheless, because the round window and round window niche are often anatomically obscured during a surgery, imaging plays a uniquely important role. Thus, radiologists should scrutinize the round window, familiarize themselves with the anomalies and disease processes that may be encountered in this important anatomic region. A brief overview. The round window membrane is a three-layered structure lined by squamous epithelium sandwiching a connective tissue layer, serving as a dynamic barrier that protects the inner ear. A locally administered drug must permeate through the round window membrane to reach the perilymph within the scala tympani. The permeability of the round window membrane can be influenced by particle size, charge, and concentration, surgical manipulations such as air suctioning nearby, and endotoxins. A locally administered drug must permeate through the round window membrane to reach the perilymph within the scala tympani. The permeability of the round window membrane can be influenced by particle size, charge, concentration, surgical manipulations. Conditions such as otitis media that promote middle-ear inflammation could also increase round window membrane permeability through the regulation of cytokines and tight junction proteins. Strategies to artificially enhance transport across the round window membrane by prolonging the time of exposure to the drug, including the use of gelatin sponge, thermoreversible hydrogels, partial digestion with collagenase, coat treatment with hyaluronic acids, or microperforations. Cochlear gene transfer studies in animal models have utilized mainly two delivery methods: direct injection through the round window membrane or intracochlear infusion through a cochleostomy. However, surgical trauma, inflammation, and hearing loss associated with these methods leads us to investigate a less invasive delivery method. Herein, in one case, they studied the feasibility of a vector transgene-soaked gelatin sponge for transgene delivery into the cochlea through an intact round window membrane. In case of Meniere's disease, the installation of gentamicin or streptomycin solution, now preferably gentamicin, into the mid-ear has been widely used as a method of suppressing vestibular function. Gentamicin percolates via the round window membrane into the inner ear and damages the dark cells which are responsible for the overproduction of the endolymph, resulting in endolymphatic hydrops. This approach avoids the risk of damaging the non-affected ear, as would occur with systemic treatments. Experimental studies are developing uses for a wide variety of agents, including steroids, local anesthetics, antioxidants, glutamate receptor antagonists, neurotrophins, and vectors for gene therapy delivered on or through the round window membrane as treatments for various inner ear disorders. Furthermore, several specific delivery systems have been developed for more controlled local applications, including the round window microcatheter. Now, this is manufactured by a company called Intra-Ear, and the microwick inserted through the tympanic membrane vent tube into the round window niche, and bone-anchored totally implantable delivery systems composed of a micropump, a drug reservoir, and a port. Now, herein we have had an extensive and comprehensive study of the round window membrane, the round window niche.